Good afternoon. Thank you very much, Kei Chong, for the kind introduction. So I have no disclosures related to this presentation. I'll be touching on how we may make use of commonly available information in our day-to-day ICU practice to help us as triggers for starting resuscitation. I'll go through pressure-targeted resuscitation and the concept of flow-targeted resuscitation and what are the targets for preload optimization based on latest evidence. So let's start with a case. This is a middle-aged gentleman, history of ischemic cardiomyopathy with EF of 35% and CKD, hypertension on 3 medications, presenting a cough, breathlessness for 3 days duration and chest pain this morning. On examination, patient is febrile, the MAP is 68 and requiring supplementary oxygen for type 1 failure. Investigation show a raised white cell count, a AKI, lactate 6.2, trop-I 200, procal 30. Chest X-ray show evidence of right lower zone infiltrates, and ECG reveal evidence of subendocardial ischemia. It's a very common patient that we encounter in the cardiac ICU. So I guess the first question is that with this MAP and this lactate, is patient in shock? Can we show our hands who think the patient is in shock? Okay, very good. So the blood pressure may not be very low, but the presence of hyperlactemia suggests there's tissue hyperperfusion, and therefore there's anaerobic metabolism and type A hyperlactemia. So remembering that absolute arterial hypotension may not be present in shock. So next, once we identify shock, lactate is important. There are many studies in hyperlactemia, and all these studies conclude one thing. If you have a normal blood pressure and you got low lactate, you are in good shape. However, if blood pressure is low or lactate is high, the outcomes are poor. And the worst outcomes are patients who have both low blood pressure and high lactate. It's not just the presence of hyperlactemia that's important, it's also the degree of lactate clearance that has got survivor prognostication information. So after we identify that patient is in shock, what do we do next? Do we spend an hour trying to identify the types of shock, or do we start hemodynamic therapy? And very often, practically, we do both concurrently. We can't spend 1 hour trying to figure out why patient is in shock. But just to go through that, even a common arterial waveform does provide us with some information on what kinds of shock patient might have. The diastolic blood pressure closely relates to vasomotor tone, and if it's low, it suggests there could be a vasodilatory component to shock. Whereas hypovolemia and cardiogenic shock, the diastolic blood pressure is usually high. Next, the pulse pressure actually correlates quite well with stroke volume and will be low in hypovolemia and cardiogenic shock. And thirdly, the upstroke of the arterial waveform, or dP over dt, gives you an idea of cardiac contractility, and that will be low in patient who has got cardiogenic shock. And in our patient, this is what we have. You realize that the diastolic blood pressure is on the lower end with a low stroke volume, and also a dPTT is impaired. So it suggests there's a component of vasodilatory and also likely a low stroke volume because of underlying LV dysfunction, and now there's a raised trop-I. So in ICU, there are many ways for us to decide what's the likely cause of hypotension, and I think the ultrasound is very useful, and for our patient, it's actually in the second clip over here. EF is poor, and patient having sepsis, as evidenced by fever, raised white cell count, high procalcitonin, but unable to mount a true response to sepsis. So now let's talk about starting hemodynamic support for this patient. So when we talk about hemodynamic support, what we meant is that we want to improve tissue perfusion, and most of the time what we do is that we try to increase the perfusion pressure. Okay, but remembering that flow is equally important. And how do we increase pressure? We aim for a MAP. And the MAP target is an area of research. We understand from data that if a MAP is less than 60, then the chance of dying is much higher. And therefore, guidelines suggested that we should aim for a MAP of at least 65 millimeters mercury as a start point. And some researchers have tried to increase the MAP target from 65 to 75 and 85, and shown that higher MAP targets may not help in terms of oxygen delivery, and also show that there might not be any harm in doing that. But mind you, these are patients who have got a normal cardiac index to begin with, and when they increase the vasopressors to aim for higher MAP, the SVRI remains well within physiological limits, which means that if you use vasopressors and aim for a higher MAP target in a patient who has got baseline LV dysfunction and your SVRI is outside your physiological range, you could likely cause harm. So this is the sepsis PEM trial. They show a low versus high blood pressure targets again. It did not show any evidence of mortality benefit. But in a subgroup analysis for patients who are chronically hypertensive, it shows that a higher MAP target likely reduce a chance for AKI development and also the need for RRT. It's not difficult to know why, because in chronic hypertension, the autoregulatory curve is shifted to the right. And therefore, we need a higher perfusion pressure to maintain the same organ blood flow. So the end conclusion is that we need to individualize target blood pressure during resuscitation in ICU. So let's talk about our methods of improving MAP. Do you give fluids, do you give vasopressors, or do you give an inotropes? So usually in ICU, we start fluids and vasopressors concurrently. There's no recommendation that you must complete your fluid resuscitation before starting vasopressors. So let's talk about vasopressors first. So this is a SOAP2 trial that Prof. Chen has mentioned earlier on. They've shown that dopamine versus norepinephrine, there might not be a difference in mortality, but a subgroup analysis of patients who has got a cardiogenic component, they tend to do better with norepinephrine simply because of the fact that dopamine is more erythromogenic, causing AF, VT, and VF. And therefore, norepinephrine might be a good choice to start for patients who are in shock. And some of us may have taken part in this survey study by ESICM. And for those of us who took part in the study, actually majority of us, close to 97%, agree that norepinephrine is likely our first choice of agent to treat shock in our ICU. So let's go back to the case. So this patient is in shock because of hyperlactemia, likely a mixed vasodilatory and cardiogenic shock. Target MAP, we aim higher because this patient is known to be chronic hypertensive on 3 medications, and now it's evidence of AKI. First choice vasopressor based on recommendations could be norepinephrine. So for patients who have got poor heart function, I routinely put them on continuous cardiac output monitoring while I up-titrate the norepinephrine, because I am concerned that I may cause excessive vasoconstriction and impairment of LV function. Okay, and noradrenaline was up-titrated slowly to 0.5 mics per kg per minute. So this is what we had at the start of the patient care, and this is what we had 6 hours later. So the MAP did improve, and of course SVRI did get higher. Can I have a show of hands how many of you are happy with the results? The MAP got higher, that's what we wanted, right? Higher mean arterial pressure for organ perfusion. Or how many of you are not happy? Okay, thank you. And I guess that beyond looking at MAP and of course looking at our other parameters of flow, we noticed that the cardiac index dropped, and of course the SCVO2 also dropped. If you want to have some other biochemistry numbers, I will show you that the lactate is 6.2 and now it's 6.0, and the CO2 gap remains high. So it suggests that it's impairment of flow, at least there's end organ tissue hyperperfusion. So why does it occur? The MAP is better. Why is patient not getting better perfusion to the tissues? And this comes this concept of hemodynamic coherence. Okay, so we know that there's no true relationship between mean arterial pressure and cardiac output. There's no relationship except for severe hypovolemia. You give patient fluid boluses, the preload increases, the stroke volume increases, the cardiac output increases, and the MAP increases concurrently. Apart from that, in your ICU, by aiming for high MAP with high dose of vasopressors doesn't necessarily mean that your cardiac index gets better. It may be the same, or your CI may actually drop because of the high LV afterload. And data has shown that by aiming for higher mean arterial pressure, we do not necessarily improve tissue perfusion. And in fact, you may actually worsen tissue perfusion because of arteriolar vasoconstriction as illustrated in this diagram. After a patient was given phenylephrine, a pure alpha-1 agonist, you realize that there's less blood flow in the microcirculation. And therefore, it's been shown that a liberal use of vasopressors with little regard for global tissue perfusion is likely to be a bad idea. You need to be more conservative in using vasopressors and pay more regard and respect to global tissue perfusion. So now there's more data that, yeah, the map is good, okay, but champagne porter, not yet. Look at what you've done to the microcirculation. There might not be good flow at the tissue level. Hold your champagne porter first, okay? So remember, map alone shouldn't be the target nor the endpoint of resuscitation. And having a good map alone with no consideration for flow is likely a bad idea. So there are now a lot of studies and algorithms talking about a tissue perfusion-based resuscitation strategy beyond just macrocirculatory, but looking at microcirculation and tissue-based indices like SCVO2, CO2 gap, arterial lactate, so on and so forth. Therefore, we need to have a pressure target, yes. We also should have a flow target and also a target for tissue oxygenation in our ICU practice. So now we're talking about flow. So flow means cardiac output, SCVO2, and CO2 gap. Okay? So cardiac output can be measured via echo. Okay? You can measure stroke volume because it's equals to LVOT area multiplied by LVOT stroke distance. Okay? And it's helpful to do echo because it allows us to look for other causes of hypotension, like what Prof. Chen mentioned, a dynamic LVOT obstruction can occur because of high dose of inner pressure in our practice. And we'll not know that until we do an echo and see a systolic anterior motion or the anterior mitral valve leaflets. Okay? However, echo is not continuous. Echo is operator dependent, and therefore its limitations in using echo alone to guide us. So there are some form of continuous or near continuous cardiac output monitoring device. For example, a PA catheter. For example, a transpulmonary thermodilution techniques. Or for example, a pulse contour analysis can give you some information. But knowing that all these devices have their own limitations, especially when patients are on high-dose vasopressors. So now we can use other information that we could have obtained easily, like SCVO2. Can I check if anyone actually measured SCVO2 routinely in your practice? Okay. Not many people. Okay. I do. So there's data to show that even if you have optimized the mean arterial pressure and you can start to prepare for your champagne, actually patient could still have a high lactate and a low SCVO2, and it portends a poor prognosis. And before people tell me that no, SCVO2 is not useful because it's one of the method in the bundle of care in the TREE trial, they've shown that early goal direct therapy is not helpful. But mind you, you look at the baseline SCVO2 in the TREE trial is 70%. There's nothing to talk about in terms of optimization of SCVO2 in these 3 trials. Compared to the early reverse trial, the SCVO2 is only 50%, which means the SCVO2 titration was never studied in the TREE trial properly because the TREE trial are looking at bundle of care, but SCVO2 was already 70% pre-randomization. Okay? So let's talk about SCVO2. So this is a DO2, VO2 graph. And we know that VO2 is important because we need oxygen to produce energy to protect our cells and protect our cytoskeleton. And the DO2, VO2 ratio is about 5:1, which means that we consume 1/5 of the oxygen delivered out from the left ventricle, and therefore the SVO2 or SCVO2 is close to 80%. The first part of the curve is what we call the supply-independent phase. When DO2 drops, the VO2 remains, and therefore patient is still okay. After a critical threshold is reached, any further drop in DO2 will result in a drop in VO2, which means that oxygen consumption reduces and patient goes into anaerobic metabolism, and that's when lactate actually rises up quite fast. So again, SCVO2 is a balance of VO2 versus DO2, and DO2 depends on cardiac output and arterial oxygen concentration. And arterial oxygen concentration depends, of course, on your HB and on your SaO2. And SCVO2 can be obtained so commonly and so easily in your ICU patients. You can get some blood out from your CVC. We can flow in a fiber optic wire through one of the lumen, or you can get one of these proprietary catheters that come with a built-in fiber optic function. I've been shown again that a drop in SpCO2 precedes a drop in mean arterial pressure. Okay? Next concept for flow-targeted resuscitation is to measure a CO2 gap. Can I check if any one of you do that routinely in your clinical practice? CO2 gap? Very good. So CO2 gap, again, have been shown to be very helpful in patients who might have a normal or supranormal SpCO2. You can see from this chart, I'll go through with you. So the first point is that the open triangle shows a patient with a high CO2 gap, and the closed circle shows that patient with a normal CO2 gap. So these patients may have the same mean arterial pressure, the same SpCO2, but the high CO2 gap patient have a much lower cardiac index and a slower resolution of lactic acidosis, and also a slower resolution of SOFA score. So the CO2 gap is a marker of your efferent flow and your cardiac index. It's been built into many research algorithms to have your CO2 gap built in as a marker of the need for further inotropic support. And not only the macro circulation, it's been shown that a high CO2 gap also shows a disturbance in your micro circulation. And therefore, the CO2 gap is a marker of adequacy of venous blood to remove CO2. And in patient in CVC, which most of your patients will have in the ICU, do consider measuring SpCO2 and CO2 gap to assess adequacy of cardiac output. So now that we've found that there's disturbance of flow in our patient, what should we do next? Should we give fluids or should we give inotropes? So we know that fluid therapy has been problematic for many years. We know that liberal administration of fluid therapy actually results in longer days of mechanical ventilation, longer length of ICU stay, and trend towards mortality. So it always advised to assess for fluid responsiveness before giving patient fluids. And we have been traditionally using what I call static markers of preload, for example, a wedge pressure or a CVP. But you look through the diagram, it showed that a CVP of 10, 11, 50% of patients may be fluid deficit. The other 50% are fluid overloaded. So it's nothing different from training a coin. So we shouldn't really be using static markers of preload such as CVP or wedge pressure to assess for fluid responsiveness in the ICU. What we should be doing is a dynamic marker. So for example, you can see from this diagram that patient A is not a fluid responder, whereas patient B is a fluid responder because the stroke volume improved by 15%. But how do you know if the patient in front of you in bed 7 in the ICU is he patient A or patient B? The traditional way is we give patient volume. And what do we do next? We pray. We pray that blood pressure gets better. But we don't do that in clinical practice anymore. We want to be more scientific. So if a patient are on mechanical ventilator and fulfill these 4 broad criteria, they are passive, they are not triggering, they are not on some mixed mode like SINV. The tidal volume is at least 8 mL per kg. There's no significant arrhythmias like atrial fibrillation, and there's no significant RV dysfunction. We can make use of what we call respiratory phasic variation. Because we know that during mechanical ventilation, there are predictable changes in intrathoracic pressure and heart-lung interactions. For example, during mechanical inspiration, there will be a reduction in RV preload, increase in RV afterload, increase in LV preload, reduction in LV afterload. Okay? And the reverse occur in exhalation. And this swing in the blood pressure or variability will just be more exaggerated if patients hypovolemic. It's been shown that such things like a stroke volume variation, pulse pressure variation, systolic pressure variation is more sensitive and more specific in detecting a fluid responder compared to usual static markers such as wedge pressure or right atrial pressure alone. Okay, so use dynamic markers rather than static markers. However, some patients are not intubated, they're on BiPAP, they're on SINV mode, and they don't fulfill all these criteria. What we should do is a passive leg risk maneuver by causing an auto-transfusion of blood into the central chest cavity to try to stretch the left ventricle and see if the stroke volume gets better. And it must be a stroke volume improvement and not a rise in MAP. There are a lot of people use. It must be a stroke volume because MAP is a surrogate of a lot of parameters. if patient get pain, when you raise up the leg, the MEP will go up. But you're not going to get higher blood pressure by giving fluids later on. So you do need to have stroke volume device before and after leg raise, either by echo, a stroke volume monitoring device like pulse contour analysis, or even using an ETCO2, because ETCO2 depends on your primary blood flow. A rise in PETCO2 with passive leg raise does suggest patient likely is a fluid responder. So this is the algorithm I use in my ICU. Is it in shock? If in shock, does it fulfill the criteria for respiratory variations? If yes, check for all the variability indices. If no, we do a passive leg raise and measure a rise in stroke volume. And is the patient fluid responsive? If not responsive, start inotrope vasopressors. If responsive, check for any contraindication to fluid loading like B-lines on lung ultrasound. If yes, don't give volume. Only when patient's fluid responsive and no contraindication do we give patient volume. So back to our patient, right? So this patient has achieved the MEP target or going to achieve a MEP target, but it's evidence of a low flow state because of a low SCVO2 and a high CO2 gap. So what we did is that we put in a balloon pump, added some dobutamine, and because balloon pump has been put in, we cannot rely on pulse contour analysis anymore, so it changed to a transpulmonary thermal dilution method. And anyway, if you're on high dose of vasopressors, your pulse contour analysis method that's uncalibrated is unlikely to be very accurate. So transpulmonary thermal dilution is better in this case. We can see the MEP actually got better, and your SVRI dropped slightly, and your CI improved, so that your SCVO2 got better, and of course, lactate came down and CO2 gap became smaller. So overall, that's the time for us to have champagne, okay? So in summary, for the diagnosis of shock, I think that it's important to look at both the MEP and lactate, because patients who have normotensive but hyperlactemia is always bad news, okay? To identify type of shock, you can use your diastolic blood pressure, your pulse pressure, so on and so forth to know. Or better still, have a direct look in the heart for the type of shock your patient have. Pressure-targeted resuscitation in for a MEP, and the MEP should always be individualized and not the same MEP for bed 1 to bed 10 in the ICU. For patients who are chronic hypertensive, they likely require higher MEP targets. Preload optimization, if patient is intubated, fulfill criteria, use all your pulse pressure variation, stroke volume variation. If not, do a passive leg raise and check for a rise in your stroke volume. And flow-targeted resuscitation is very important, do not forget. If you have a central venous catheter, you can easily take some blood out to do SCVO2 and your CO2 gap. If not, you can put on some form of continuous cardiac output monitoring. Take-home messages. Critically ill patients are heterogeneous in baseline characteristics, acute physiological derangements, and their responses to therapy. They are very different. It's a challenge. Individualized hemodynamic targets to restore tissue perfusion. Next. Avoid focusing only on MEP, which do not truly reflect and may even impair tissue perfusion if you use more and more vasopressors. Consider integrating flow targets like SCVO2, CO2 gap, and lactate, which better reflect global perfusion in your clinical management. Thank you very much.
So thanks, Woon. I guess we have just time for one question. By question by Imran. So how do you actually manage all these targets in the face of atrial fibrillation?
Which target? SCVO2, CO2 gap?
Well, in particular for the hemodynamic monitors that often rely on sinus rhythm.
So I guess the flow targets such as SCVO2 and your CO2 gap, you can measure even in atrial fibrillation. So that's not an issue. And even on echo, when we use echo to estimate the stroke volume, we do average over a number of cardiac cycles. So long you average out, then you reduce this chance effect. But all your variability based on your heart-lung interactions will not be accurate anymore. So cannot use any stroke volume variation anymore.
Right. So yeah, thanks a lot. So I guess the meeting is to average it out, right? So thanks a lot, Woon. Thanks again.